Hi, and welcome to Rad Onc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria, and I am currently a PGY5 resident at the University of Pittsburgh. With today's talk, I'll be adding to our introductory series with a discussion of various acronyms and lingo that are very commonly used in radiation oncology. When I was a medical student and even a junior resident just starting out my Rad Onc journey, I would often hear various letters and acronyms and kind of abbreviations just thrown around left and right, and I didn't understand what a lot of them meant, and not all of them were straightforward to even Google and understand. And I wish someone had kind of sat down and explained to me what each of these acronyms mean. My hope with this talk is to do exactly that. And what I'm going to try to do is sort of walk through the process of a patient that's treated with radiation from start to finish and try to kind of bucket these various acronyms along various stages of the treatment planning process. And remember, in radiation oncology, we're basically just using radiation therapy to treat various conditions. Most commonly, we're going to be treating cancer with radiation, but we do also sometimes treat benign conditions. Regardless, the first step in getting a patient started on their treatment planning process is to first see them in consultation and kind of discuss the recommended treatment, what it entails, go over all of the logistics, side effects, and so on of treatment. And once they're signed up for treatment, we begin the treatment planning process. The very first part of treatment planning is to obtain a simulation scan. This is often a CT scan that's done in the department, and the goal of the CT simulation is to obtain a CT image or a CAT scan, computed tomography imaging, of the patient in the same exact position that they're going to be in for every single treatment. Radiation is going to be delivered from the outside in, and we really don't want the patient to move. We want the radiation to go exactly where it's supposed to go with each treatment. And so during the simulation, the radiation therapist, depending on what site we're treating, will take different measures to immobilize the patient for simulation. And so what might that include? Well, if we're treating something in the brain or in the head and neck, we worry about their head rotating, their neck, their shoulders, and so we'll apply a mask, a thermoplastic mask over their head, neck, and shoulders to kind of hold all of that area still. If we're treating them in the pelvis, for example, we might actually give them special instructions to either have their bladder full or have their bladder empty. We might ask them to have a bowel movement before treatment, just to kind of try to immobilize or try to kind of consistently position the bladder and the rectum from day to day. If we're treating an extremity like an arm or a leg, we might think about how the radiation beams are actually going to give the radiation treatment and deliver it, and we might ask them to immobilize their arms or legs a certain way. That's all a simulation is, really. It's just getting a CT scan of the patient in that treatment position so that we can then design a radiation plan that's specific to our patient's anatomy. And this is often abbreviated SIM or CT SIM. And you might hear an attending say, I have to go to SIM, or SIM is paging me. And that just means they're going to the CT scanner for the simulation. Now, the reason that attendings are often called to CT simulation is to place what is known as the isocenter, often abbreviated as ISO. Now, what does that mean? What is an isocenter, and what does it mean to place the ISO? The isocenter is the central point in our treatment room when we are actually delivering the radiation. So in most cases, our radiation is delivered in the form of photons or high energy X-rays from a linear accelerator. And linear accelerators are called LINACs for short. So the LINAC will deliver the radiation, and it'll usually shine a beam of radiation to whatever area we need to deliver. The isocenter typically correlates to the central axis of that radiation beam. And so it's important to set the isocenter in a place that is in the center of our intended treatment field. so that that central axis of the beam kind of overlaps with the very center of our intended treatment field. And so when we are placing isocenter or ISO at the time of simulation, all we're doing is telling our treatment team where we want the center of our treatment field to be. So for example, if we're treating a prostate, we will put the isocenter in the center of the prostate. If we're treating a lung tumor, we'll put the isocenter in the center of that lung tumor. Once we drop that isocenter in the computer and we tell the computer this is the center of our intended treatment field, the system will then calculate points on the patient's skin that the therapist can actually line up to with lasers in the simulation room, and then they will mark that patient's skin, usually on the side of their body and then also on the top of their body. And then each time they come in for treatment, they'll get lined up to those same marks. And ideally, those marks correspond to what we said is the isocenter, and then the radiation can be delivered centered around that point that we kind of told the computer we want to be the isocenter. So it sounds very complicated, but it's actually very simple. When we set the ISO, we're basically telling everyone else in our entire treatment team, this is what we want to be the center of our radiation field. Now, different centers will do it differently. So some centers will actually go ahead and place the ISO in the center of our intended treatment field. But even when we do that, and even when we put those tattoo marks or whatever type of marks on the patient's skin to line them up every day, sometimes there are what we call shifts, where at the time of treatment, we get an image and things aren't lining up perfectly, so then we actually have to shift the patient in various directions. Some centers will just always mark the patient the same way, so they'll always put the ISO like at the belly button or something, and they'll always mark the patient consistently, and then the therapists know they have to shift to the true treatment isocenter. So there's different ways of doing it, but that's really, I think it's important to understand what is an isocenter, what does it mean when you go to CT Sim to place the ISO, and hopefully this helps to kind of elucidate what that means. If patients are just getting a run-of-the-mill CT scan for their simulation, and if we're treating something like the prostate, for example, you'll just get a CT scan, you'll place the isocenter, you'll mark the patient, and then they're good to go. However, for targets that are close to the lung, like anything inside of the lung, anything in the mediastinum, things that are close to the diaphragm that are in the abdomen, so things like the liver, adrenal glands, or things like that, we need to account for motion, right? Because while the patient's lying on the table, they have to breathe. And as they breathe in and out, that tumor is going to move. So we will get what we call a motion study. This is also sometimes called a 4D study because we're tracking the tumor across time, that fourth dimension, as the patient breathes in and out. When we get a motion study, what we do is we basically track the patient as they're breathing, and we track their various cycles of breathing from their deep inspiratory phase to their deep exhalation phase. And we kind of put the CT scan images that we get into different buckets based on what phase of breathing that patient is in. And then we combine all those phases together, and then we have the information on how much the patient is moving. In order to get a smooth motion study and to kind of smoothly bucket these CT images into various buckets of the breathing cycle, the patient needs to be breathing steadily. They need to kind of be breathing slowly and steadily and not very erratically. This can be hard for some patients, especially patients that have underlying lung disease and older patients and things like that. And so sometimes we might get a motion study and actually use what we call coaching or coached breathing. All that is a track that we usually play or instructions that we give the patient to breathe in and breathe out at timed intervals. And that helps us to kind of regulate their breathing so that we can acquire a smoother motion study and adequately obtain the information. Now, when we have that motion study, we obtain information on how much the tumor is moving. And then once we have that information, we need to figure out what to do with that info or how to manage the motion. How are we going to manage the patient's motion as they're breathing? And so there are many different kind of routes that we can go with motion management. So one option, if the tumor is not moving a whole lot, is to just treat the patient free breathing and just increase our field in terms of the treatment radiation, right? If the tumor is moving up and down during the breathing cycle, then we just kind of widen our field to make sure that we're encompassing it that entire time. And if tumors are, small and they're not moving a whole lot, then free breathing is certainly an option because it's not too toxic to kind of increase the amount of radiation that we're giving the patient or to kind of increase our field size. Sometimes, however, tumors are going to be really bouncy, especially tumors that are close to the diaphragm. They might move up and down a whole lot. And so in that case, when we're hesitant to treat with free breathing because our field just has to be so wide to encompass it, we then start to worry about causing unnecessary toxicity. And so in that case, we might do an approach that we call gating, where we know that the patient has, say they have 10 different phases while they're breathing. We can only treat them during the central phases, let's say. So we usually divide these phases into 0, 10, 20, 30, 40, all the way up to 90. And we'll only treat them from phase 20 to 80 or from phase 30 to 70. So we kind of narrow our field size, and we only treat the tumor when the patient is in particular phases of breathing. And so that is what we call gated treatment. The other thing that we can do is modify the patient's own breathing, right? So one thing that you can do for tumors that are either in the abdomen or very close to the diaphragm and the lung, like in the lower aspect of the lung, we can apply abdominal compression. So this is actually quite uncomfortable for patients, but it's basically a device that presses on their belly and prevents them from being able to breathe in very deeply. As you can imagine, when you press down on someone's belly really hard, they're not able to expand and contract as much with their diaphragm, and so their breathing becomes more shallow. So that's another way that we can kind of limit the amount of motion. And then another way that's very commonly used is something called deep inspiratory breath hold, or DIBH, where we actually ask the patient to just take a deep breath in and hold. And the disadvantage of this technique is that, patients can only hold their breath for so long, and so we can only deliver the radiation when they're holding their breath, and the treatment takes longer. But it can have several advantages, especially in breast cancers. For example, if you're treating a left-sided breast cancer, that left breast sits right in front of the heart. So we often ask these patients to do DIBH, or deep inspiratory breath hold, and that creates some space between the chest wall and the patient's heart, and it also expands the lung, and it just helps us to protect the lungs and the heart a little bit more from radiation. So that's another thing that's really important for us to consider at the time of simulation is kind of, are there things that can move and how are we going to account for those? So we typically want to obtain a motion study and then think about if they need any sort of motion management and how we're going to approach that. Once we obtain the CT scan at the time of simulation, the images that we obtained at the time of CT are imported into our treatment planning system, and that's usually done by our team of dosimetrists. These CT scanning images are imported for us to actually do the treatment planning on, and whenever they import images, it's really important for them to import the correct images. So for example, if you acquired a motion study and you're treating free breathing, then it's important for them to import all of the phases from that motion study that were acquired. These images are then brought into our treatment planning system, and sometimes we might need to perform what we call a fusion or a registration. Now, what does that mean? So sometimes when we're doing our treatment planning and when we're contouring our target volumes, it's important for us to see not just the CT scan at the time of simulation, but some other diagnostic imaging that they had. So sometimes we want to see the MRI that a patient had. We might want to see their PET scan. We might want to see a CT scan with contrast if they had a CT scan with contrast previously. And so different images that might be useful to us when we're actually doing our contouring, we'll ask our dosimetrist to bring those in also and fuse them or register them is another way of saying that, to our CT simulation. Basically what that means is to try and align the images as close as possible. Now this can actually be really hard because number one, when we take a CT simulation, we immobilize the patient very, very carefully. This is often not the case when they get a diagnostic imaging and their position is different from diagnostic imaging to the time of CT simulation. Another key difference is that usually diagnostic CT scans will have a curved table that the patient lays on. Our CT simulations actually have a flat table because our treatment machines have a flat table. And so these are subtle differences that can make it difficult to overlay different diagnostic images to our CT simulation images. So there's different types of registrations that our dosimetrists can do to help us to align these images. One type of registration is what is known as a rigid registration, where basically the dosimetrists just take the same, the diagnostic scan and they take the CT scan and they overlay them and they can move them in the lateral, vertical, or basically the X, Y, and Z axis, or they can kind of rotate them along different planes to line things up as best as possible. Sometimes, however, they will also create what is known as a deformable registration. And deformable registrations are different because they're kind of used to account for subtle changes in head rotation that you might see with head and neck cancer patients and things like that. Deformable registrations basically alter the relationship between different pixels, and they try to account for different changes in the shape or the size or the position. So I think a good example of this is how they try to account for subtle rotation of the chin between a diagnostic image versus the CT simulation. So it's just good to be aware of different types of registrations that we can use. Most often, I think we're going to be using rigid registrations, but dosimetry performs these critical tasks and then sends the images to us so that we can actually work on our contours. Contouring is one of the most important treatment planning tasks that we perform as radiation oncologists. It's similar to our surgery, right? When we contour on the CT simulation scan, we are telling our treatment planning system what are our target volumes, so where do we want the radiation to go, and what are our organs at risk, so where do we want the radiation to be minimized. And so there are different abbreviations that we use for various structures. So our target volumes all end in TV. We typically start by contouring the GTV, which is the gross tumor volume. That is typically the tumor that you can see with your naked eye on the patient's imaging. A CTV is a clinical target volume, and it's really meant to account for microscopic spread of disease that we cannot see with our naked eye. So sometimes we will add an extra margin onto our GTV, and that extra margin, whether it's half a centimeter, 1 centimeter, 1.5 centimeters, that is kind of dictated based on the disease site and various protocols for that disease site. But it's just a margin to account for potential microscopic spread of the tumor that we just can't see with our eyes. Another type of CTV that we will often draw is for elective nodal coverage. So there are some disease sites, such as head and neck cancer or gynecologic cancers or prostate cancer, where in certain scenarios you will have what we call elective nodal coverage. So we don't see that cancer has spread to those nodes just yet, but because we know based on data that it has a high propensity of spreading there, we electively cover those nodes even though we don't see that cancer has spread yet, just because the chances are very likely that there might be a microscopic cell here or there. And so that volume, if we do cover elective nodes, would also be known as a CTV, or a clinical target volume. Another type of volume that we often will draw is internal target volume, or an ITV. We don't always need to draw an ITV, but it's really to account for internal motion of an organ. So if we're drawing a lung tumor that moves, or if we're drawing something in the liver that moves up and down while the patient is breathing, we will not just draw the GTV in one phase of their breathing, but we will actually contour an ITV and account for what happens to that tumor as the patient moves, as they breathe in and out. So ITV is really to account for internal motion. And then finally, we have our PTV, which is a planning target volume. And that is to account for external motion. And it's external motion that can happen both interfraction as well as intrafraction. So interfraction, what could happen? There might be minuscule errors in day-to-day setup. We give our therapists very precise instructions. They properly align to the marks on the patient's skin. We even get imaging sometimes to confirm setup, but there can still be some minor day-to-day errors on the order of millimeters often. And so we do include a planning target volume to account for that error. Also, what can happen is intrafraction. So within the patient's treatment, the patient might wiggle. We use all these fancy immobilization techniques, but despite that, the patient still do have a little bit of wiggle room. And so if they swallow or something, or if there's tiny little movements that alter the anatomy, the PTV margin is really an additional margin to account for that. The protocols for the CTV margin, how to draw the GTV, how to draw the ITV, what types of margins to add for the PTV, they are all really based on different clinical trials and what those trials have done. PTV margins are often based on institutional practice and the comfort level with setup within an institution. So there's variation in centers across centers in terms of how that is done. Other than the target volumes, we also need to contour the stuff that we want to protect. So those are our organs at risk, or OARs. So say you are treating a lung tumor. The organs at risk are going to be things nearby that we want to protect, like the heart, the esophagus, the spinal cord, the normal lungs, things like that. So those are all of your organs at risk. And then finally, the planning risk volume, or the PRV, is kind of the equivalent of an ITV, but for the OAR. So with a planning risk volume, sometimes we will add an additional margin, or we will contour our organs at risk to account for the motion of that organ at risk. We don't always do this. So just because we're drawing an ITV for our tumor doesn't always mean that we'll be drawing a PRV for our organ at risk. But we often use this when we're delivering a very high dose per fraction, or our target volume is very, very close to a supercritical structure like the stomach or the duodenum or something like that. And we really, really want to take all the extra precautions to protect that organ at risk. That's when we'll draw the PRV, or the planning risk volume. But hopefully this gives a good kind of overview of our target volumes and our organs at risk, and what we're thinking about as we do these contours. Once we draw our contours and we feel happy with them, we'll actually put in a prescription. So we'll actually say, this is the dose of radiation that I want to go to this particular target volume, and we typically prescribe our radiation dose to a PTV. And we specify how many fractions we want that radiation to be given in. So all of our radiation is typically given as a certain amount of dose across a certain amount of fractions, and each fraction is a treatment. So most of our radiation regimens are typically on the orders of days to weeks, and so the dose of radiation that we give is divided up across many different fractions. And so once we submit that prescription and we submit our contours to our planning team of dosimetrists, they work behind the scenes to come up with an appropriate radiotherapy plan. Now, I've tried to make a table here with some of the most common acronyms that you might see used when it comes to radiotherapy and different modalities. So RT or XRT is common abbreviations that you might see just for radiation in general. And very broadly, radiation is divided into external beam radiation therapy, or EBRT, versus brachytherapy. So brachytherapy is a kind of a specialized procedure that we do in radiation, and brachy just means short, so short distance radiation therapy. And common ways of delivering brachytherapy are with radioactive isotopes that are actually implanted inside of the organ that we're treating. So there's low dose rate brachytherapy, and there's also high dose rate brachytherapy. With low dose rate brachytherapy, it's such a low dose rate that we actually permanently implant radioactive seeds into the area that we're treating. This is often used for prostate cancer. And those radioactive seeds remain radioactive for a period of weeks to months. And then because of their half-life, they basically decay and are no longer clinically radioactive after a certain point. So that's low dose rate brachytherapy, often used for prostate cancer. And we often call that seed implants, where we put low dose rate isotopes inside of the prostate. High dose rate brachytherapy is delivered usually using an iridium-192 source, which is a higher energy radioactive seed. And typically this is used for treating things like gynecologic cancer. It can also be used to treat prostate cancer. But because this is a higher energy, it's not at all safe to permanently implant it into the patient. And so we actually will deliver that type of radiation using a machine known as an afterloader that is connected to a catheter that's inserted inside of the patient, and then it delivers the seed for a brief period of time, and then that seed is extracted. So brachytherapy is more procedural, and this is sort of not the standard type of radiation, and it's kind of a different realm of radiation that we're not going to go into too much detail about in this talk. The other type of radiation that's most commonly what you think of when we're treating with radiation is external beam radiotherapy, or EBRT. Now, within external beam radiation, there are many different techniques, and over decades that radiotherapy has been utilized, we have become more and more advanced with our radiation techniques. So in an older era, like 20, 30 years ago, a lot of times radiation was delivered using a two-dimensional approach. So with 2D radiation, I kind of just think of it as shining a flashlight on a patient's body and treating everything that lights up from that flashlight. These are very simple plans. You can basically draw a field, and everything within that field gets radiation. That's two-dimensional radiation. We made some advancements and moved the needle and went towards three-dimensional radiation. And with three-dimensional radiation, we were actually able to obtain a CT scan. We were able to contour out organs at risk as well as our target volumes. And we were able to kind of calculate the dose and things like that to those important structures. And so with three-dimensional radiation, we also started using fancier techniques like wedges or field-in-field technique to kind of better shape and modify the dose distribution. We then had IMRT, which is intensity modulated radiotherapy. And IMRT really relies on these things called multi-leaf collimators that are in the head of the gantry, or MLCs. They're like lead leaflets that move in and out of the field while the patient is being treated. And they allow for radiation to be delivered very conformally to our target. A subset of IMRT is something called VMAT, which is volumetric arc therapy. And with VMAT, we can actually continuously deliver radiation as a beam moves in an arc around the patient. And continuously, as that beam is delivering radiation, that the MLCs are constantly moving in and out. They are constantly modulating the beam and really conformally shaping our radiation dose to the target. And then finally, we have something called stereotactic radiation. So stereotactic radiosurgery or stereotactic body radiotherapy are acronyms that you might hear used. SRS typically applies for intracranial disease, and then SBRT is typically used for other sites like spine SBRT or body SBRT. But they're the same thing. Now, instead of delivering our radiation every day in small fractions of radiation, we are actually delivering much higher doses of radiation with each fraction, and we're delivering the radiation often in just 1 to 5 treatments. So with SRS and SBRT plans, we end up getting very, very conformal dose distributions, where the target volume is very nicely covered by the intended treatment dose. The center of that target volume is actually very hot, meaning that the dose is very high in the center of the target. Typically somewhere on the order of 110 to 120% of what we actually prescribed. And then as you move away from the target, we have a really nice fall off with SBRT plans. So that's kind of in a nutshell an overview of how our radiation techniques have improved. And this particular diagram really is just talking about photon beam radiotherapy. So X-ray therapy or radiation that we would deliver using a LINAC. There are other types of radiation. We will sometimes use electrons, which can also be delivered via LINACs. And then there's also particle beam therapy, including protons, which are delivered with different machines. And we're really not going to get into that too much here. But just know that, various institutions may have proton centers, which allow for different modalities of radiation as well. So here is just an image to show you what a 2D versus a 3D versus an IMRT plan might look like. If we look at a dose cloud representing the same dose of radiation, with a 2D plan, regardless of what volume we draw, we don't have a whole lot of control over where that radiation goes. And so you can see that a huge area outside of our intended treatment volume is actually covered by the radiation dose. With 3D conformal radiation, we're starting to see that dose cloud is better shaped to our treatment target. However, we still have quite a bit of spill outside of the intended treatment volume, and it's better, but it's not perfect. With intensity modulated radiotherapy now, with that same level dose and dose cloud, we can see that the dose is much more nicely conformal to the target volume, and we don't have a lot of extra dose spilling outside of our target. So there are still, depending on what site we're treating, what the indication for radiation is, what dose of radiation we're giving, even in the modern era, there may still be indications for 2-dimensional versus 3-dimensional radiotherapy. So it's not wrong to use these treatments, and sometimes they're even better and more quicker and more effective for certain patients. And so it really just depends on what the goal of your treatment is, what your patient looks like, what dose you're giving, and a lot of different factors to determine what type of therapy you would use. But I think this image just kind of nicely shows what advantages we might have from an IMRT plan, especially if we're treating in an area with near critical structures like in the head and neck, where that spinal cord is right there. And it also kind of goes to show, how conformal these plans can be. Here are some more examples of IMRT, and in the top image, you can see what those multi-leaf collimators look like, or MLCs. They have, widths that really vary in width, but they can be anywhere from, I think, 5 millimeters to a centimeter, typically on the order of millimeters. But these MLCs can move in and out of our treatment field, and they can move dynamically while the radiation is being delivered. And that's where the intensity modulated radiation therapy name comes from. We're not actually modulating the intensity of the beam as it leaves the machine, but what we are modulating is really its fluence, meaning where that beam is hitting the patient based on the movement of these MLCs. And as there's different types of IMRT. There's step and shoot IMRT, where the beam moves into one position, delivers the radiation, moves into another position, delivers the radiation. Sometimes, those MLCs can move dynamically while the radiation is being delivered. And then the volumetric arc therapy, or VMAT, is a type of radiation where the beam is moving continually around the patient, and the entire time it's moving, those MLCs are dynamically fluttering in and out of our field, really conformally shaping to our target. So depending on, again, the area that we're treating and our purpose of treatment and things like that, VMAT can certainly have its advantages, but there may be situations where you would actually prefer just your traditional IMRT over a VMAT plan. Now, I mentioned how when we ask our dosimetrist to create a treatment plan, we provide them with a prescription dose. So we let them know, this is my target volume and this is the dose that I want the target volume to get. We also let them know what our organs at risk are and what are our limits for those organs at risk. We'll often set like maximum dose on a particular organ or a volumetric dose or a mean dose, and we let them, and sometimes we'll set multiple constraints for a single organ, but we basically let them know, this is what I want to treat and this is what I can tolerate in terms of my normal structures. When we prescribe our dose, one thing that we might often consider is something called a boost. So depending on what you're treating, what disease site, oftentimes we will have, and this applies to many different disease sites, but we will have what we call a boost, where a larger volume of our treatment gets a lower dose, and then a smaller volume gets a higher dose of radiation. We see this sometimes in breast cancer, we see it with brain tumors, we see it when we're treating the pelvis for prostate cancer and we're doing elective nodal coverage. We see it for head and neck cancers. So there's many different times where you have kind of a larger volume getting a low dose and then a smaller volume getting a higher dose. And we call that higher dose a boost region. And there's typically two different PTVs in that situation. You'll have a PTV getting a lower dose and a PTV getting a higher dose. There's two different ways that boost can be delivered. So the first option is to do what we call a sequential boost, where we give the same dose per fraction and we'll give a certain number of fractions, and then after that number of fractions is reached, we will narrow down our fields and continue to give the same dose per fraction for additional fractions, but now we're just treating a narrower field, which is our boost volume. So that approach is called a sequential boost, and sometimes you'll hear people say cone down. So you'll say, oh, I treated this volume and then I did a cone down to this dose. That just means that that boost was delivered sequentially. So the same dose per fraction usually, but then we just gave more fractions to that smaller volume. The other option for delivering a boost is what we call a simultaneous integrated boost. So this time we're giving the same number of fractions to all of the volume, but a smaller volume is getting a higher dose per fraction compared to the larger volume. And that approach, where we're kind of treating the same number of fractions, but different dose per fraction, depending on which volume we're treating, that approach is called a simultaneous integrated boost, and it's often abbreviated SIB. Or SIB or SIB. So you might hear people say, oh, I SIB'd this to 60 gray, or I SIB'd the lumpectomy cavity to whatever. So that terminology, the SIB, is just telling you that they used a simultaneous integrated boost, whereas cone down typically indicates that they used a sequential boost. Once we've put in our prescription and once our dosimetrists have designed a treatment plan using whatever modality, say they did a VMAT plan, they'll then send that plan to us for review. And another critical part of our job as physicians is to review the radiation plan and make sure that it meets our standards and that we feel that it's safe to deliver. So when we're reviewing the plan, one of the things that you might notice is what energy of beam that was used for the treatment. And these are all concepts that will probably come more to light in physics classes if you do pursue radiation oncology. But there's different energies that we can use in external beam radiation, and they're often called something like 6x or 10x or 15x or 18x. All that means is the energy in MV or megavolts. So if you see like a 6x beam is being used, that means that it's a 6 MV energy beam. Sometimes you might see the letters FFF added to the end of that energy. So you might see that this plan used 6x FFF beams. What does that mean? What is FFF? So FFF stands for flattening filter free. So what is a flattening filter? Well, when you think about how a beam is delivered, a beam, if you look across the horizontal axis of a beam, it kind of looks like a normal distribution curve. So the dose is highest along the central point of the beam, and on the sides, it's kind of shorter. And so typically when we deliver radiation, we will insert what is known as a flattening filter that sort of differentially attenuates the beam across that horizontal axis so that when you look at the horizontal axis of a beam, it's more symmetrical and it's more, I shouldn't use the word symmetrical, it's more kind of homogeneous across that horizontal axis. So typically we use a flattening filter. The advantages of the flattening filter are that you have a more homogeneous dose and the mean dose across that beam is higher because of that flattening filter. When we take out the flattening filter, that beam returns to its original position and it gets that peaked distribution again. We often will take out the flattening filter when we're doing stereotactic plans just because the dose is delivered faster that way. By doing that, we are decreasing the average energy because now the sides of the field are getting lower doses. But with stereotactic radiation, the way that that's planned, it's actually okay. It's just advantageous to treat FFF or flattening filter free because that treatment is delivered faster by virtue of flattening filter free. So again, details that will come more to light in future physics classes, but I do think it's good to just be aware of what the energies mean and what FFF means. And then finally, I think it's important to kind of note the distinction between dose versus monitor units. So the dose in gray is what we would prescribe as physicians. Like, this is the dose of radiation that I want to go to this PTV. Monitor units are then what the machine actually delivers. So typically our machines are calibrated so that 1 centigrade is 1 monitor unit. But it's good to just kind of keep an eye on the monitor units that are being delivered for a particular radiation plan, because that is kind of a marker of how hard our machine is working to deliver the radiation that we want it to deliver, and also a marker of how much time it's going to take for us to deliver that radiation. One of the most important things that we will look at when we review plans, other than seeing kind of the spatial dose distribution, is something known as the dose volume histogram, or the DVH. So when we look at a plan, we do like to see what the actual dose distribution looks like on a patient, and that can either be seen using isodose lines or a dose cloud. We can kind of see what level of dose is corresponding to what area on that CT simulation. However, we can also plot the different structures that we drew, the target volumes as well as the organs at risk, on what is known as a DVH, or a dose volume histogram. And basically, we're plotting the dose on the x-axis against the volume on the y-axis, and it tells us what volume of each organ is getting what dose. So we typically want our target volumes in the upper right corner of the DVH curve, meaning that as much as possible of our target volumes are receiving 100% of the dose. And we typically want our OARs to be in the bottom left of the DVH curve, meaning that these organs are getting as little dose as we can manage. If we like our radiation plan, and we then approve that radiation plan, our treatment team will work to schedule our patients for treatment, and then they will start coming in. Now, in the olden days, we often used to rely very, very heavily on those tattoos that we would place on patients to line them up in the room, and it was really based on that we would treat. And if anything, we would be able to acquire what is called a portal image, or an MV portal image, meaning we get an image of what it looks like from the beam's eye view, like the machine as it's delivering the treatment. From that very angle, what does the image look like? And we would acquire, it's called an MV portal because the image was acquired with MV, or mega voltage level x-rays, the same energy of x-rays that we actually use for treatment. And that was kind of it's more of an outdated way of kind of confirming that we're treating exactly what we want to treat. It is still useful in the modern day in certain clinical scenarios, but now we have more sophisticated ways of imaging the patient at the time of treatment to confirm that our radiation is going exactly where we want it to. So when we get some type of imaging at the time of treatment to confirm that the treatment is going exactly where we want it to, other than MV portal imaging, we call that IGRT, or image-guided radiotherapy. All that means is we are not just relying on the marks on the patient and an MV portal image, we are actually getting some other type of imaging to help us with our setup and to make sure that the radiation is going exactly where we want it to. So let's go over some of the most common types of IGRT. MV images and KV images are often how we kind of in shorthand refer to just basically x-rays that we get at the time of treatment to confirm that the patient is set up correctly. So we might get an MV-MV image, meaning we'll get like a AP-MV and a lateral MV. Or we might get a KV-KV image, meaning we'll get an AP-KV and a lateral KV image. Now, for reasons that we won't spend too much time on here and that you will learn in physics class, MV and KV images look very different. MV is much better at soft tissue contrast. So if you're imaging something like the breast and you're trying to line up to treat the breast, MVs might be very useful. KVs are lower energy, but they are much better at highlighting bone because they are more dependent on the Z, or the atomic number of the material that we're imaging. So KV images are better to image bone. So if you're trying to treat something in the spine and you're trying to do something simple, a KV image is good to kind of line up to the bone. So KVs and MVs, think of these as just kind of x-rays. And the reason that these MVs are different from the MV port films that we previously talked about is because there's a separate sort of appendage on the linear accelerator that actually acquires these images. It's not acquired from the same head of the treatment machine that's going to be delivering the therapeutic radiation. In the modern era, what we will often acquire for IGRT is what we call a cone beam CT. So when we think about a diagnostic CT, it's typically a spiral CT or a helical CT or a fan beam CT. What that means is when we are circling the CT scanner around a patient, we're just acquiring an image of a very thin section at a time. It's used for diagnostic images. It does yield kind of a higher radiation dose, but it gives us a better soft tissue resolution. Cone beam CT, on the other hand, is our approach for image-guided radiotherapy, or IGRT. And with a cone beam CT, we are scanning a larger section of the patient at a given time. It does result in less radiation dose, and sometimes it can be faster, and it allows for us to kind of focus on smaller areas because it tends to have higher pixel resolution. But if you look kind of side to side, comparing the fan beam CT versus the cone beam CT, the fan beam CT sometimes is easier to kind of clearly see structures, but cone beam CT is good enough for our radiation purposes to kind of line up to the correct organ and make sure that the dose is going exactly where we want it to go. So those are just some examples of onboard imaging that we can obtain for IGRT. In the modern era, most of the time I would say patients are getting some form of IGRT. What I will say is just because we have kind of more advanced techniques like the ability to get CBCT imaging, that doesn't mean that MV portal images are not valuable to us. And there are still certain times where we might actually just prefer to be very quick, especially if we're doing a palliative treatment or something like that. An MV portal image might be enough for us. We have all these tools in our toolbox, just like we have, IMRT and VMAT compared to older kind of 2D and 3D planning techniques. These are just more tools in our toolbox, and sometimes it's appropriate for us to use these more advanced modalities, and sometimes it's appropriate for us to kind of just go the old school way. So everything is very much dependent on the clinical scenario. Now, while the patient is on treatment, they will, every 5 fractions, have a visit with the physician just to make sure that things are going okay and to kind of manage any toxicities from radiation as they may or may not be coming up. If you've rotated in a radiation oncology clinic, you've probably heard of OTVs, which are on-treatment visits. And all that means is a check-in. It's typically done once a week because we typically administer 1 fraction every day of the week, Monday through Friday. But sometimes if patients are on a BID treatment where they're getting treated twice a day or something like that, we might have to do it twice a week. But basically, it's just a check-in with the physician to see how they're doing, and if they're having any side effects, we discuss those and manage them at that point. But that is what an OTV means. And finally, when our patients have completed their radiation treatment, we arrange to see them in follow-up. And follow-up is also very, very important for radiation oncologists. And what we really, really care about is our patient's quality of life. And the terms that I've outlined in this diagram are terms that you might see in many studies. So our patient's QOL, or their quality of life, is really dependent on 2 main factors, right? Any toxicity that we may have caused from our radiation, as well as their oncologic outcomes. Did we help them with their disease, either by providing a local control benefit, providing a survival benefit, or whatever? Did we help them either live longer or at least prevent their disease from coming back for a longer period of time? So toxicity and oncologic outcomes. So toxicities, and these abbreviations I've included because they're really abbreviations that you might see when you're reading studies in radiation oncology. So toxicity, we think about acute toxicity, like what happens during radiation, as well as late toxicity, what happens months to years out. And there are different grading systems for toxicity. So there's RTOG grading, there's CTCAE grading, and if you're reading a paper, they'll typically specify which system they used for grading the patient's toxicity. Typically, toxicities are graded on a scale of 1 to 5. 1 to 2 are typically low. 2 is typically kind of managed with some type of medication. 3 to 5 are kind of more serious toxicities. Grade 5 toxicity is death, usually. Grade 4 toxicity is, something serious that required either an aggressive measure such as a surgery or a serious hospitalization, and grade 3 can be serious as well. So toxicities are typically graded on a scale of 1 to 5, and then there's a few different systems for grading them. And then finally, we think about our patients' oncologic outcomes. So their overall survival, their progression-free survival, disease-free survival, event-free survival, distant metastasis-free survival. There's lots of outcomes that we haven't even included here, like their local control, their local regional control, and things like that. But at the end of the day, many different things play into our patient's quality of life, and quality of life accounts for both the toxicities that we may have caused from radiation, as well as how well we actually controlled their cancer, if it is cancer that we were treating. So that brings us to an end of our overview of various acronyms and lingo that you might hear in the world of radiation oncology. This was not all-inclusive for sure. There are many, many more acronyms and random terms that are probably, not obvious to someone that's not in the radiation oncology field. But hopefully this kind of gave a decent idea of many of the unknowns, especially when you're a medical student first starting out on your radiation oncology rotations, or even a junior resident. I hope that this sheds some light on various terminology that you might not be familiar with from medical school. So that is all I have for now. If you are interested in more of an introduction to radiation oncology, this video is one that I recorded very recently. And I've actually added it to a playlist of our Introduction to Rad Onc series. And those are talks that I recorded probably over a year ago now, but they have some introductory content, including intro to clinical radiation oncology, intro to radiation biology, as well as intro to radiation physics. So if you're looking for more, I would recommend checking those out. But I hope this video was helpful to you, and thank you so much for your time and attention.